Hello, and welcome to the Christopher and Dana Reeve Paralysis Foundation webinar today. We're very lucky to have the topic of spinal cord injury and pregnancy. We have an expert in the field who's going to be helping us answer some questions today. He's board certified by the in obstetrics and gynecology, excuse me. And he works at the UVA Health Center in Charlottesville, Virginia. And welcome Dr. Robert Fuller to our panel today. It's very nice to see you.
Thank you, Linda. I appreciate that introduction.
And so, Dr. Fuller, I always ask this question because I think it kind of sets the stage, but it's just a curiosity to me. You're very proficient, an expert in the fields of obstetrics and gynecology. So what prompted your interest in spinal cord injury? What was that spark for you?
Sure, I appreciate that question. And I'll add on a little bit to your introduction for me. I am an OBGYN physician, certainly trained and qualified in that, who went on to have additional training in high-risk obstetrics. So my more complete title is that I'm a subspecialist in maternal fetal medicine. That requires additional training and research beyond normal OBGYN training, and have continued as a maternal fetal medicine physician in practice for at least 15 years or so. I don't want to give up too much of my age with my gray hair on my head. Having said all of that, maternal fetal medicine is a discipline of obstetrics that coordinates well with women who have high-risk pregnancy. So now to begin to answer your question about what sparked my interest, well, the fact is that high-risk pregnancy, people who have high-risk pregnancy will frequently see a high-risk pregnancy obstetrician or a maternal fetal medicine specialist. That was my primary exposure to seeing women with various types of physical and other disabilities. My wife is also a physical therapist who, as a part of her training, did neurodevelopmental treatment as a part of her training. And so I learned really a familiarity with individuals who have brain injury or spinal cord injury, and became more comfortable with discussing those topics. That, combined with my training in high-risk obstetrics, really just sort of led me into an intersection of taking care of more and more women over the years with spinal cord injuries who are contemplating pregnancy.
So you've had a number of years of experience in this, and we need to hear all about it. There's a lot of people who are really interested in what you have to say today. So let's start at the very beginning. Let's start for the woman who comes to see you that is contemplating pregnancy, just thinking about it. What are some of the preparation kinds of things that somebody could do if they're planning a pregnancy? I know there's a lot of women who suddenly become pregnant. They don't have time to plan the pregnancy. But are there things that a woman with spinal cord injury in particular need to do to prepare for pregnancy, and thoughts about that?
Sure. Many of the preparations that a woman with a spinal cord injury would have to prepare for pregnancy are identical to what women would just wish to have in planning for a pregnancy in general. For example, your best health is your best self. So you would want to be current in all of your health maintenance. You would like to be as fit as possible. If there's any means in which you can become healthier, we do know that women who are healthier entering pregnancy will generally have better outcomes. So the first and preliminary thing to do is just to kind of take a self-inventory, ask what those types of things each one person could do to be healthier, and to begin to work on those things. Now, sometimes that does involve speaking with, a primary care physician, or in the case of women with spinal cord injury, also discussing with their other doctors about what could be done to improve the fitness or the health of themselves. For example, a weight loss program might be beneficial. There may be habits such as tobacco smoking that may be beneficial to discontinue before becoming pregnant. And very important for all individuals who are contemplating pregnancy is to take an inventory of the medications that you may be taking. There are certainly many medications and herbal supplements that are available or prescribed for women of reproductive age, and most of those are safe during pregnancy, but some of those should be avoided. So speaking really with the team of your doctors to let them know that you're interested in becoming pregnant and you would like to begin to work with a regimen of medications that are effective, but also safe to take during pregnancy. This reduces the chance of having to make a medication change during pregnancy, at the same time not knowing if that change is going to be effective, and then having complications from a particular medical condition, such as maybe high blood pressure. In our community, for example, there is autonomic dysreflexia, which is very well managed in some cases, but if you were to begin to change the medications, it would become difficult to manage. We would not wish that to happen during a pregnancy. So becoming safer with the medication choices would also be an area of preparation. Another area to improve one's pregnancy outcome is to take prenatal vitamins and have a healthy diet and lifestyle, ideally for at least 3 to 6 months prior to a planned pregnancy. Sometimes women don't have that option. They become pregnant unexpectedly, and then there are lifestyle changes that occur because of pregnancy. But we know that if prenatal vitamins are in place and there's a good healthy lifestyle for at least 3 months prior to pregnancy, we will see better outcomes for pregnancy. The other things just generally to consider is that preparation for family building is important. And when people have the ability to prepare for an additional family member, say a child to come in, that's also helpful. It can be quite stressful during the course of a pregnancy when there is also the social questions about, like, where do we put the baby? We don't have enough room. We must move to a new apartment. Those kinds of questions can also be pretty stressful during a pregnancy. So just from a very practical standpoint, just making preparations for a new family member can ease the burden of pregnancy instead of having to manage that in the midst of a pregnancy.
So there's a lot of things to consider. And you mentioned working with the other healthcare professionals as well as to find out what kinds of things should be done, like body preparation, strengthening, because you'll be moving extra weight. And you mentioned medications as well. So are there any particular, a lot of our women take medications for spasticity and that sort of thing. So is there any any spasticity medications? I know there's some questions in the question and answer box about that. Is there any particular medications that should be avoided that you can just think of offhand? I mean, obviously we can't list every single one, but are there
That's
some
right.
that kind of rise to the top for you?
Well, as I do wish to answer that question with some level of detail, let me first discuss briefly just normal changes in pregnancy, and then what that doctor team would look like, and then it would begin to fall into place what kind of medications might need to change. First, when a woman becomes pregnant, typically that mom will have nausea and vomiting. She may have some initial weight loss. She'll have water retention, sensory aversions. There will eventually be a change in size and weight of that woman. She will grow with her pregnancy. Her baby will grow inside of her. Her center of gravity will change. And this will necessarily affect mobility. This will affect pressure points. This will affect transfers. So many of those things that people have worked so hard to be very careful with, all of those things will need to be changed during a future pregnancy. Part of the knowledge of the physiology of pregnancy includes that you are building your body to build a baby. The example that I like to use in my office very frequently is, if you can imagine that you're going from a closet in the back of your hallway and you're going to convert that closet to an airplane hangar and build a 747 in it. That is what you are doing as a mom. You are not only building a baby, but you're building all the infrastructure to support the growth of a small human inside of your body. This requires extra blood, extra nutrition, extra fluid. A mom's heart will work 50% faster and more, pump 50% more blood during pregnancy than when she's not pregnant. Anemia is expected. Changes in urinary habits, an increased risk for bladder infections. All of these are in normal pregnancy and even in higher risk for moms who have spinal cord injury. Changes in bowel habits are very common. Constipation is a leading concern among pregnant women in general, and so a bowel regimen may need to be modified in individuals with a spinal cord injury that hasn't never been tried before. So there are additional maybe medicine treatments or other treatments that have to go along with the management of these normal changes in pregnancy. I mentioned about autonomic dysreflexia, which very commonly is managed by positional changes or sometimes medications. Autonomic dysreflexia is much more likely to be active during pregnancy. Conditions that are normal in pregnancy, such as contractions or even fetal movements, can trigger autonomic dysreflexia. And of course, all pregnancies will have contractions at some point, and all babies will move. So we do understand that moms can have complications in that area of their health. Separately, we do know that many individuals with disabilities can also suffer from depression. Depression and anxiety are leading conditions that can lead us to have new moms with new babies to have difficulty in their postpartum period. So in moms that may have a history of depression or have depression as a part of their life, we have to be especially cautious that those same moms will not develop postpartum depression. And all of this, of what I just mentioned, is a part of normal pregnancy. The autonomic dysreflexia maybe being a little different with that, but all of these principles are principles that we manage in normal pregnancy, maybe more frequently and with different treatment plans in people with spinal cord injuries, but these are normal conditions that we see in normal pregnancy. Now, the team of doctors that's involved with that will include an obstetrician. Sometimes a high-risk obstetrician such as myself will be a consultant or a primary provider to that mother. But we also have normal healthcare providers for individuals who have spinal cord injuries. We have neurologists frequently, urologists, maybe orthopedists. Sometimes neurosurgeons are involved, or GI doctors as well. Frequently, there'll be a skin care team or a wound care team that can help with pressure sores or prevention of those things. The PM&R people, the physical rehab people, PTs, occupational therapy are frequently not only involved in normal care of someone with a spinal cord injury, but are more frequently involved in individuals who are pregnant with a spinal cord injury. Respiratory therapy may be involved, psychiatry, mental health concerns. As we're planning toward delivery, anesthesiology is especially important, and we can talk about that separately. Sometimes urology is involved because of surgical diversions or other things involving the urinary system. And then last but not least, after the baby is born, we now have a mom who not only has more doctor visits because she's pregnant, after the baby's born, now we have all the new doctor visits for the newborn baby, the pediatricians. Sometimes babies are born prematurely and need to stay in the hospital, and lactation consultants. Lactation consultants are especially important because we know that some medications may be safer or less safe during pregnancy. Now I would like to begin to address some of the medication, which was the beginning of the question in the first place. So why would anyone want or need to take medications during pregnancy? Well, we do know that some medications that may not be necessary outside of pregnancy can be avoided during pregnancy, but other medications that are required for maintenance of good health should either be continued or a substitute medication started that can continue good health. In most cases, an individual who's taken a medication for a chronic medical condition or a serious medical condition, in most cases, the medical condition itself is more dangerous to pregnancy than the medications are. There are a few blood thinning agents, for example, that are oral medications that we would wish to avoid in pregnancy. So someone who is taking warfarin or Coumadin, for example, we would not wish to continue that during pregnancy, but we would use a different anticoagulant medication like Lovenox or heparin, which are injectable medications. So you mentioned specific ones. For individuals who are taking oral medications to avoid or treat blood clots, we would change those to injectable medications during pregnancy because those are safer. In terms of antispasmodics, there are newer medicines that seem to work better than older ones, but sometimes the older ones work well enough. And sometimes those older ones have a more proven track record over decades of use compared to a newer medicine that might have only been on the market for 3 months. So there are times that we may wish to change from newer medications and use other ones that might be slightly less effective, but still effective because we have a higher safety profile. Certain antibiotics are also avoided during pregnancy generally. Some of the antibiotics come in and out of the news as to which ones are, more safe or more dangerous. But the tried and true ones are the old penicillins and cephalosporins that we've had for not quite 100 years now, but we're going on that type of length of time. Whereas the newer antibiotics may not have as high of a safety profile that we have. So we may end up changing antibiotic choices for individuals who are taking antibiotics for urinary tract infections, for example. Cardiovascular complications in pregnancy are a leading reason why women will have death or bad outcomes in pregnancy. So sometimes our moms with spinal cord injury are also taking cardiovascular medications. Often the newer ones are more effective, and that's why they're selected. But some of the newer ones are harmful to a developing baby, and some of the older medications can be just as effective and just need to be chosen either for the duration of the pregnancy or maybe at least through the first trimester before an alternative newer medication may be desirable. So without really giving a lot of very detailed information, because there are hundreds and hundreds of medications that can go up for questions here, there are principles involved. The principles are to avoid medications that are not necessary, to use the safest, most effective medication that we can choose from, even if it means choosing a medication that's a little less effective than one that is newer and more effective. And sometimes when medications are required throughout the entire pregnancy, we can avoid them maybe in the first trimester while the baby is forming its organs, and then continuing them through the rest of the pregnancy and postpartum, and have a very good outcome simply by skipping maybe a few weeks of taking a certain medication and then resuming that again.
Well, that certainly says a lot. And I would just like to add on to that, that if you are a woman and you're pregnant and you have not had an episode of autonomic dysreflexia, if you have a higher level of spinal cord injury, to be sure and beware of those symptoms, because sometimes pregnancy is going to be the thing that's going to trigger your first AD episode. And we have a wallet card for that at the Reeve Foundation. So if you don't have that wallet card, be sure and download that so you'll know all the symptoms, because I know in the rehabilitation setting, you're taught, oh, you get a pounding headache. And that is true. That's the cardinal symptoms, but there are many other symptoms as well. And so treating things early is more effective than waiting until later. And like you were saying about the antibiotics, if you suspect a UTI or if you suspect something, please get it treated early, because earlier is ready, right? Is better, right? Earlier treatment is always easier.
Yeah, and to speak toward a urinary tract infection, an ascending urinary tract infection from the bladder to the kidneys is a leading complication that we do see in all pregnancies, and it can be life-threatening. So whenever we identify bacteria in the urine, even if it's asymptomatic, during pregnancy, we will frequently treat that because it will go on to prevent a more serious kidney infection that can truly be very life-threatening to the mom, put mom in the ICU, result in an early delivery, sometimes even before a baby is able to survive. So we do manage urinary tract infections much more aggressively during pregnancy, and we do also manage blood pressure much more aggressive during pregnancy as a rule. Every patient is different though, and so every patient does need to have an evaluation for their health status and what their frequency of those types of complications are in order to devise a best plan.
Okay, so now we've got a woman. She comes to you. She's pregnant. Yay! Well, I guess maybe we should talk about if there are difficulties getting pregnant. Are there certain things that you would do? Would you do anything differently with somebody who's, so far we hear it's pretty much the same. The risk factors are the same, and maybe just a little more magnified in some cases with spinal cord injury. But if somebody is trying to get pregnant, it's just not happening, is there anything that can be done there?
Sure, I appreciate that. A preconception or a pre-pregnancy appointment with the doctors is always very helpful. That's what we just discussed. Now the mom has decided, yep, I'm going to, do these things, and I'm looking for pregnancy, and I've been trying for 6 months, and I'm still not pregnant. Doctor, is there something wrong? Okay, that's a great question to ask. As it turns out, that most healthy women who have no fertility issues should be able to expect to get pregnant within 12 months. So not getting pregnant right away is not a concern. In fact, 6 to 12 months after attempting pregnancy is not unusual. But if a healthy woman with no reproductive concerns, and by the way, a spinal cord injury is not a reproductive concern, The general approach of fertility being unaffected by a spinal cord injury is absolutely true. So having said that, if a woman with a spinal cord injury is not pregnant at 6 months, we usually will say, well, try for another 6 months. After 12 months of a younger aged, reproductively capable woman who has given herself ample opportunity to become pregnant, and that's a whole separate seminar, by the way, ample opportunity to get pregnant, at 12 months, that would be the trigger point to do a further investigation to figure out why. Sometimes the investigation leads us to the male partner, the male factor, may be an issue for the fertility in the couple, or maybe it is the woman who has some other undiagnosed fertility concern. But we give that 12 months before we look. The only exception to that is if we have an older aged mom, say older than 40, approaching 45 years old, we realize that capacity for fertility becomes limited after those ages. So at that point, we may only wish to wait 6 months before we endeavor on a more comprehensive evaluation. To summarize, we give our moms 12 months, just like we would in any other gynecologic situation to achieve pregnancy, with the exception of our older aged moms, more than about 40, we're more inclined to not wait a full 12 months for fertility because we know that fertility is limited more in that aged group of women.
And interesting, somebody had written in a question while you were answering that. And it just is really it's a question of what you just kind of told us, but have you ever had a patient in their late 40s get pregnant and have a child and any additional complications because of age and SEI, which you just really answered. But have you had many patients in their late 40s get pregnant and have a child?
Oh, yes, I'm at the University of Virginia now. I would say at any point in time in our practice currently, we have at least a half a dozen women, at least, who are in the range of 42 to 45, 46 years old who are pregnant. Very recently, we had a woman over 50 years of age without fertility assistant have a child. It is not uncommon for us to see women who are over 40 to have children. Now, infertility issues are more common in that age group. And in terms of pregnancy complications, we do see a much higher incidence of miscarriage, birth defects, genetic and chromosome issues in the baby. And we see a much higher incidence of diabetes, hypertension, and stillbirth. All of those are risks for any woman who becomes pregnant. But after about 40 to 45 years old, those risks begin to dominate. And so having a healthy child after about 45 years old is more exceptional than it is common. But all of those risks that I just told you, those are risks that exist in every pregnancy. When you're 25, those risks are pretty low. But when you're 45, the combination of those risks is quite high. In fact, high enough where I would expect that a woman who is 45 years old, who is pregnant in my practice, even without a spinal cord injury, is expected to have some type of complication. It may not be pregnancy limiting, and we still may have a good outcome, but at 45 years of age, we can anticipate that there will be some form of complication during her pregnancy.
So you've got this woman now, she's pregnant, here she is. And during the pregnancy, is there anything else that they should be thinking about, especially with a spinal cord injury? Is there any other issues that should be concerning to them?
Sure. Pregnancy is a state of higher risk compared to not being pregnant. It is just a normal fact of human reproduction that there are just going to be risks in any pregnancy. As a part of the pre-pregnancy consultation, we do know that there's risks, just like I just said about the 45-year-old mom. All of those risks have been reviewed in a preconception consult. And during the course of the pregnancy, we will begin to find out if those risks come true or not. In other words, we'll find out if diabetes develops or if hypertension complications develop during the pregnancy while she is having her prenatal care. In terms of unusual or different things that are set aside for individuals with spinal cord injuries, we do have a higher risk for urinary tract infection, blood clots, pneumonia for immobility. We have a higher risk for complications that are related to immobility, such as pressure sores or injuries during transfers or falls. We do have a higher risk for cardiovascular events in individuals who have spinal cord injuries who are pregnant compared to those women who do not have spinal cord injuries. We do have to be on the lookout for all of those complications. By far, the most common results of those types of complications will be problems with the autonomic dysreflexia, sometimes issues related to the need for an early delivery, and hospitalizations. Hospitalizations are much more likely for women with a spinal cord injury because of complications that are difficult to manage and verify that they're being adequately treated in the outpatient setting. A normal prenatal care set of visits is about 12 to 14 visits. So once a mom has become pregnant, she can count on at least a dozen visits to her doctor during her pregnancy, and that's only to the obstetrician. If there's a urologist involved or a neurologist involved, that's additional visits. Toward the end of the pregnancy, there are likely to be consultations with the anesthesiologist, which, by the way, is an important part of the healthcare team because the best way to manage AD complications is with a spinal administration of medications, which is perfect for us for women in labor or in women that need C-sections, because we can administer the medication that allows us to have a more pleasant labor or have a C-section, and at the same time control autonomic dysreflexia through the medications that can be administered in a spinal. So it becomes quite busy in terms of prenatal care appointments. We're on the lookout all the time for any of the common complications that can occur. And for those with appropriate ability to recognize the SCI specific concerns, we're paying very close attention to mom's symptoms or potential complications that moms may not realize that they have because of the nature of their injury.
So in talking about those that have AD, that usually comes with the higher level injury in the cervical and thoracic, the lumbar sacral, not so much. Is there quite a bit of difference in pregnancy between those with a higher level injury versus those with a lower level injury? Do you notice that much difference?
Yes, we certainly do. The autonomic dysreflexia begins to become more of an issue for individuals who have an injury at about the T6 level or higher. For women that have an injury or some spinal complication, and this may include individuals who have a neural tube defect, spina bifida, for example, with surgery, and now they have a degree of paralysis and lower spine dysfunction, but not necessarily the upper extremities or autonomic dysreflexia. We do see a significant difference in risk in women who have, I'll just say that, higher level injuries than lower level injuries. So we do see that it definitely is the case. And I don't want to make light of autonomic dysreflexia. Every person who has a spinal cord injury with autonomic dysreflexia will tend to have a pattern of their symptoms and their signs that go along with their particular type of AD. It is very important to recognize not only that pattern, but also to recognize that there may be new and different symptoms that you have just said to us. New and different symptoms can occur that did not occur outside of pregnancy. So sometimes there's new learning and new education. Individuals with those lower level spinal cord injuries do not have that particular concern, which does significantly lower their risks for many complications and hospitalization in pregnancy.
So in talking about the risk, I'm going to ask a hard question, but I know our listeners are going to want to know. Is there any contraindication that you would say to somebody? Perhaps it's better that you not carry your own child, or do you ever counsel in that direction?
Yes, ma'am. I'm as a maternal fetal doctor, I am that guy. I'm that guy that gives the hard news. Sometimes it can be difficult to hear or to give, even in pregnancy when complications are developing that nobody would ever want anyone to ever have. I'm that guy that gives that news. So yes, ma'am, I'm familiar with counseling women for those conditions for which they should not become pregnant. In this audience, I am very, very fine and secure to say that a spinal cord injury is not a contraindication to pregnancy. Women with spinal cord injuries, no matter at what level, can attain pregnancy and have a normal, healthy pregnancy. There is a much higher chance for complications. So when we've talked about these complications, many of these complications are manageable. A few years later, a mom is very grateful that she had her baby and now she's home with her child. And even though her pregnancy was hard, one of the wonderful things about pregnancy, and it's a very fascinating topic to talk about, pregnancy-related trauma and the ability for women's brains to disassociate pregnancy trauma with the joy of having a child. So it is often the case that I'll hear a mom that her pregnancy was the worst thing that she ever had, but I want another one. And it really is quite amazing that the brain in pregnant women is configured that way due to the hormones of her pregnancy. So it's really quite fascinating. So a spinal cord injury is not a contraindication to pregnancy or future pregnancy, even if there's been a history of a prior difficult pregnancy. Contraindications for us would be major cardiovascular disease. If a woman's heart is very unhealthy, then we can use measures of that to predict maternal death. There are certain hypertension conditions, pulmonary hypertension being one of them. It's a cardiothoracic complication that men and women can have, that in many cases, it's safer to not be pregnant than to have a pregnancy with that particular condition. Although I have taken care of many women with very serious cardiothoracic and cardiovascular diseases and help them have healthy pregnancies. There are only a handful of conditions for which we would recommend not having pregnancy. One thing I think it is worth discussing is the general risk of life during pregnancy. The United States is not the model citizen in terms of maternal mortality rates. You don't have, this is on the news, this is no secret. We don't understand in the United States why our maternal mortality rates are as high as they are. But this is a subject of serious interest and serious research for us to figure out why do we in the United States have a higher maternal mortality rate. And a maternal mortality is a death from pregnancy that occurs during pregnancy or within the first 7 weeks after a baby is born. The maternal mortality rate in the United States, most recently reported, is about 23 women die out of every 100,000 babies that are born alive. There is a racial disparity. The racial rate is that approximately 50 women die out of 100,000 live births, compared to about 23 to 24 white women. So 53 Black women die compared to 23 to 24 white women die in that same group of live-born babies. Older age is a big factor. So overall, the maternal mortality rate is about 23 or 24 per 100,000, but after 40, the maternal mortality rate is 110. So it's 4 or 5 times higher simply from being older than 40. That's your chances of dying. And this is all women. Disabilities further increase some of that risk. What really is important to understand is that we don't have current data. We have to always look at older data and compare older information to older information. But the most current information that we have, not only is there an age-related risk for just dying in pregnancy, not only is there a racial and other disparity-related risk, but there's also a risk for individuals with disabilities. A most recent paper published in JAMA reviewed the statistics from over a decade ago, because that's the best data was, and showed that women with a disability, and in that study, by the way, it's about 1% of all women that are birthing children, about 1% of all women birthing children will have some form of disability. Of those disabilities, about 85% of those disabilities are physical disabilities. So the majority of women who have a disability have identified as having a physical disability of one type or another. That group of women has an 11 times higher risk of dying than if they did not have a disability. There's about a 6 times higher risk for having a clot, about a 4 times higher risk that can lead to death, and a 4 or 5 times higher risk of having a cardiovascular complication. Your initial question was like, well, what are the contraindications for pregnancy? Well, I'm able to tell you that spinal cord injuries are not a complication or not a contraindication to pregnancy, but someone who is familiar with this level of risk should provide the counseling for the women, ideally in those pre-pregnancy times, to give a realistic level of risk and determine if that woman who wants to be pregnant, is she willing to accept that level of risk? So a 45-year-old African-American woman with a disability has a very much higher level of risk than someone who is 25, a different race, and without a disability. So it's important just to understand that there are risks built into pregnancy and related to disability in general. And I'm not speaking specifically of spinal cord injuries. I'm talking about disability in general that are just inherent to being pregnant. For women that are willing to accept that level of risk, there are doctors like me who are willing to see those women, minimize that risk, and manage any complications that come along. So that's why we do say that pregnancy is not contraindicated, but there are some women who will choose not to become pregnant when they understand what those risks are.
And following up on that, there was a question that just came in about has the risk factors improved for women in spinal cord injury, say over the last 20 years? Have they stayed about the same? Are we making progress? I guess is what the really question is asking. Are they making progress with improving risk? And it sounds to me like with all your preparation, that is progress, because you're going to try to avoid things happen. We can't control everything, but has there been improvement over the years?
So the answer to that question is yes. In the areas that we've improved is we do know that we have when moms, and I'm going to say this very carefully, when moms are survivors of their pregnancy and we have babies who are survivors of the pregnancy, everyone is healthier than they used to be. We have not made a big dent on, say, these mortality rates. We have lowered them down somewhat, but still we're not leading the world. So there does seem to be a certain amount of risk reduction that we can achieve. But in those women who were able to manage those risks, we are able to have healthier moms and healthier babies. So we do see that we're making progress, but not in all areas. It is, as you know, as this organization knows, it is difficult to convince a lot of people to do research in disability populations. And we know most of our risks and how to manage them based on individuals who do not have disabilities, and we get general principles from there. And then separately, for individuals with a spinal cord injury, we do have individuals such as myself and other specialists who have special training in it, but that special training is not widespread enough so that it's dispensed to the general medical community. So we still do need to have moms who have spinal cord injuries see specialists, because it is difficult to attain, in many small communities especially, it is difficult to attain high-level obstetrical care in pregnancy, and to be able to see the doctors that really make the biggest impact in smaller communities, simply because the smaller communities don't have the deep filing of experts to help take care of a pregnancy at risk. And one last comment I do want to say is not all spinal cord injury pregnancies have that same risk. We just stratified a little bit by level of injury. If an individual has a very low, lumbar spinal cord injury and their limitation is only related to just mobility, that woman has a much, much lower risk and is much more comparable to a woman without a disability than a woman with a much more profound spinal cord injury. So there is sort of a gradation level of risk that should be discussed. It's not black and white.
There's a lot of factors. Let's talk about the delivery. And there's some specific questions. You've already answered the question about AD and delivery. So we've talked about that. There's a couple other things that are really pressing on people's mind. One is you talked about spinal anesthesia. And the question is about those women who have rods that have been placed because of their spinal cord repair, and that always comes up. And then the other question is about medications during delivery, because there is a segment of people out there in our society that will say, well, you have a spinal cord injury, you don't have feeling, so you don't need any medication, even though their body's still responding to the pregnancy. So could you talk a little bit about those issues? I know they're both really loaded questions. So
Sure. And if I omit a question, please just interrupt me and get me back on track with that, because there were several different questions there.
Yeah, it was a loaded bunch.
The delivery route can and should be vaginal delivery for women with a spinal cord injury. There's not a need for a C-section. However, if a C-section is required, we do have to have surgical anesthesia. Surgical anesthesia is either going to require a spinal or an epidural injection of medicine in the spine, or it's going to require general anesthesia. General anesthesia is the least desirable form of anesthesia that a pregnant woman can have. We see a much higher risk for death and difficulty coming off the respirator with general anesthesia, much more so than if a woman were not pregnant. So our preferred means to have a C-section would be to have a spinal or an epidural. And I also do appreciate that that is a difficult subject for some women who may be paralyzed because they had a spinal or an epidural. And that is a real hard thing. We can't coerce anyone to do anything that they don't wish to do. But if we need to have adequate pain relief, we only have a handful of options. Now, in terms of, not feeling something, well, your body inside feels things, even though your brain may not quite get the message. In other words, your body does have reflexes. Your body will have a response for high blood pressure, for example, if you have pain. Pain often is not perceived as pain like I feel it and I'm going to yell the word ouch, but your body can perceive pain by releasing catecholamines like adrenaline, and that can cause your heart to race and have your blood pressure go up. So your body does have a physiologic response to discomfort, even if your brain may not feel it as pain. Also, pain can be perceived as nausea and vomiting. Pain can be perceived as syncope or passing out or fainting, changes in blood pressure. A spinal cord injury does make people more prone, especially above a certain level. T6 makes people prone to have problems with blood pressure regulation, but anybody can pass out during labor from having low blood pressure or going into sort of like a fainting spell. The concept of anesthesia to help with pain begins at the level of about T10. Now I'm talking about spinal cord levels. I'm not talking about vertebra levels, but the T10, about the T10 vertebra, I should say. So in order to have adequate relief for pain during labor or discomfort during labor, we have to block below T10 and down. So if your spinal injury is at L2, then you're still going to experience symptoms of pain or discomfort of some sort during labor, because we need to block you below T10 and down to eliminate most of that. So depending on where your level is, you may not even have something that's equivalent to a spinal or an epidural, even though people who may not understand may just assume that if you have paralysis of your legs, you must have anesthesia too. That's always not the case. So the options for a spinal or an epidural in labor are the same for women with spinal cord injuries as women who don't have them. Separately, if there is a need for like tissue repair or relaxation of muscles, spinals and epidurals do well to relax muscles and can reduce spasticity tremendously. Whereas if you don't have adequate anesthesia, we may have complications with spontaneous muscle movement or spasticity during labor. And that can cause joint injuries. The legs do have to be out of the way for a baby to come out. So people have to move those legs into position, or those legs have to stay in stirrups of some type. Now, often this can be done in a bed and there can be assistance. A patient's partner, for example, can hold a leg, but spasticity can be very powerful. And if that spasticity is not appropriately managed, someone who's holding a leg can easily be thrown to the floor. And then that leg is no longer controlled and we can have a joint injury in the hip. So we should assume that people with spinal cord injuries need the same level of anesthesia, same amount of muscular relaxation, and the same amount of joint protection as anybody else who is having a pregnancy. So there really should not be restrictions on those types of treatments for labor and delivery. If moms are taking medicines on a regular basis to maintain their spasticity, we would encourage moms to continue to take those medicines during the time of labor and delivery also, because if it is helping them not have spastic muscle activity, then we would like to continue that through the course of their labor and delivery. We don't want new problems at the time of labor and delivery. And you may have asked some more questions and I've forgotten about them already. What else is there for me to talk?
The big question is about the epidural or spinal anesthesia, which generally the person bends forward to open up the space.
Oh. Mm-hmm.
But when the rods are there, you can't bend forward, so it becomes very difficult. But is it impossible?
No, it's not impossible. And in fact, the positioning of the rods and the vertebra still allow a needle to pass through those intervertebral spaces. Those spaces are larger when a person curls forward. So the advantage of curling forward is it gives the anesthesiologist a larger area in which to insert the needle correctly. An appropriately trained, skilled anesthesiologist can typically navigate between the vertebra, even when rods are in place. So we do not find that having Harrington rods or other fusions or spine immobilizing treatments, we don't find that that necessarily limits us. If we do encounter a situation where we cannot provide those types of anesthesia, like into the spine, there are other more high level types of anesthesia where we can block specific nerves as they leave the spinal cord. That requires a little bit more advanced training on the part of the anesthesiologist. There's imaging, real-time imaging involved. It's ultrasound, it's safe, but that does involve more careful, precise needle placement and injection of anesthetic into the nerve roots as they originate out of the spine. These are very specific types of blocks. They can be done in labor, but when a woman is pushing out a baby, a woman usually is not holding still enough for us to do that. And so there are also times that we may not be able to achieve a level of anesthesia that we wish at the time of delivery. If we end up with AD symptoms that we can't manage from the spine, we'll manage them in other ways. We'll just give IV medications or other treatments as we need to manage blood pressure.
And speaking of that, there's a question that just came in, and this person said, how can a woman with a spinal cord injury have a vaginal delivery since they can't push voluntarily?
That's a great question.
Isn't
And
it?
yeah, and this is just truly one of the most remarkable things that I'm going to say that I hope everyone on the podcast here will appreciate and be in awe of. A woman who is unconscious can have a baby out of her vagina simply by the uterine contractions that are occurring. This can happen. We have women in comas, for example, who can have a vaginal delivery, go into labor, their cervix will dilate, and the uterine contractions are sufficient to push the baby out of her body. A different way to kind of think about this is, when you have stuff in your stomach and your body wants to throw up, you don't really squeeze up your stomach to vomit. It's a reflex that causes the vomiting to come out. And I understand that with spinal cord injuries, there may be a bowel regimen, but the typical reflex to empty one's bowel isn't something that people concentrate on. You may have to relax enough to kind of let the muscles loosen up, but the process of defecating is a very coordinated, reflexive process. I understand spinal cord injuries interfere with that, but the normal process is just a reflexive process to have stool pushed out of the body. Well, as it turns out, uterine contractions require no pushing whatsoever. And there are some medical conditions where we do not want a mom to hold her breath and push, because that process creates intrathoracic pressure that can be dangerous. So there are some medical conditions where which we purposefully ask women to not push. If the baby comes out on its own, that's great. And if not, then we can use instruments. And I know that's also up for discussion and debate among the obstetrics community. But we also can use instruments to facilitate the delivery of the baby out of the birth canal, such as vacuums or forceps. If there is danger or trouble for the baby to be delivered quickly, sometimes we talk about using those instruments. But a mom's uterus can push a baby out on its own. As long as baby is tolerating the process and as long as mom is tolerating the process, there's never a need for a mom to push a single time, and we can still have a baby vaginally.
And here's another interesting question, and I'm sure you'll love this one because I'm waiting to hear your answer. Is there anything in the pregnancy journey of women with spinal cord injury that is positively different than other expectant mothers?
Oh, that's a great question. I would say that where I do hear the most positive comments would be in a mom who is in labor and she hasn't received pain medicine yet at all, and she feels comfortable in labor. In other words, this wouldn't be the mom with AD where we're, trying to get the blood pressure in control, but this will be a mom maybe with, paraplegia, and she comes in and she thought she was in labor because she could feel her tummy tightening up and she's feeling some pressure. So she came in and yeah, she's like 4 or 5 centimeters dilated. And so she gets admitted to the hospital and, we start talking about the anesthesia. And next time we check her, she's like 8 or 9 centimeters dilated. And she just looks up and she says, this hasn't been so bad at all. So there is the case where we do see women with spinal cord injuries, especially with a certain degree of anesthesia, may not feel as much discomfort from labor. So that is a positive that I do see in some women with spinal cord injury. Other than that, really the joy of going through pregnancy for most women at the end of it all is being able to hold their baby. One of the most positive things that I can see from taking care of any mother, spinal cord injury or not, is when we lift the baby up to the chest of our mom wraps her arms around her baby that she is touching and holding for the first time. And she begins to maybe to cry or maybe giggle senselessly. And everybody is just so happy. That truly is a special and remarkable event. And what I would definitely like to encourage anyone, spinal cord injury or not, is to be hopeful for that event after you have childbirth, where you get to hold your baby for the first time, and you get and that's a spark and a magic that is so special that I don't even really have words for that. I wouldn't say that's unique to women with spinal cord injury, but I will say that women with spinal cord injury who maybe have believed a lot of their life that they would never be pregnant, maybe they couldn't find a partner, maybe they didn't think they could have a baby, when they hold that baby for their first time, it really is remarkable. So I think that is an elation that I can't explain any other way.
Well, I know you're taking me right back to when I had my baby in it. Yes, I know exactly what you're talking about. You describe it so beautifully. It makes me think of that was what it was all about. That moment was just beyond words. There's several questions which people have written in, and I hope that the people who wrote those questions can see that you've answered them throughout the process. A lot of questions about AD and medications, and you said that's individual for different people, and you might need to substitute. So I hope that the answers have reached the people. There is a question from one of our associate organizations, Hope Live, which is an organization that helps people manage their funds to get fundraising. And the question is there any particular place do you know of any place where people who have spinal cord injury can turn to funding for pregnancy issues, for equipment, or maybe travel to get to that spinal cord specialist? Do you know of any kind of funding that's available to women?
That's a really wonderful question. Of course, I work at the university now, and we're a safety net organization. So we do have a number of social work programs in place for vouchers for travel for patients. Many women who are pregnant qualify for a Medicare or Medicaid type of insurance program. Many people who have a spinal cord injury are already familiar with that, maybe through Medicare, for example. But Medicaid is a branch that covers pregnancy based on income alone, for example. So for individuals who have limited resources, frequently we can coordinate with say our state or federal insurers to provide vouchers to get people to travel to needed appointments. Now, I have to confess that I am at such a sort of an executive level of understanding that I don't have the details as to how the wheels actually turn and how the gears interlock. But I do know that I have patients that if they're in a certain location and they need assistance to travel to see us, we usually can come up with some form of assistance to help with that. But that also might be because I work at a university, state university, and we may just have different types of resources than others who may not see a large university like mine, or they may go to a private hospital or a different type of community setting. So I wish that I had clear answers for that. I'd be interested in knowing some of those answers and helping discover that if that's possible. So for that group who's entered into the chat, I'd be interested in gathering some of that information and helping give that if I can.
Well, and I think that if you do live in some rural areas, most places are connected in those individual states with the larger state facilities, and they do have similar programs. So I think that's fairly universal. I think tapping into that might be a challenge. If you don't, if you're not aware of it, facility where you are going might not be aware of it. And so, a lot of this is a lot of work on the individual's part to try to dig into these things. It makes me think too with telemedicine that has become so ever present. Have you ever been involved with a telemedicine birth in or consultation or
Uh-huh.
I
Well,
mean it's new,
I
so I
think
don't know.
the telemedicine birth, I think would just sort of be an interesting thing to kind of to go through. Put me up on the iPhone and me yelling push, push. I can just see funny variants of that popping up on TikTok. But in terms of telemedicine, we do use telemedicine, and we became very good at that with the coronavirus
Mhm.
pandemic. Some individuals with very major medical issues who would be safer, maybe not traveling to a clinic or a hospital at the height of the pandemic, we did telemedicine visits. And for even for a few people, um, as I've had patients in my area come to see me at the University of Virginia, even with spinal cord injury, we were able to do some telemedicine visits during the pandemic. Telemedicine has not fallen out of favor, but there are some things that we can only assess in person, particularly in
Right.
pregnancy. And so we cannot do the majority of our management by telemedicine. We do have to collect laboratories, and we do have specific physical exams that we should do at certain times in the pregnancy that we really can't use telemedicine as a substitute. Laboratories sometimes can work out where an individual can travel to a local laboratory station and have blood collected, and we can use those results. But more times than not, there are pregnancy-related specific questions that seeing someone or doing an ultrasound, for example, just requires an in-person visit that we can't get around otherwise.
So maybe if you do live in one of these rural areas and that individual would still need to travel to see someone like you in their own state, or if they live closer to you, but there are some options to help reduce some of those fees if you
There,
can
there are, and
substitute every once in a while or do a lab
mhm,
someplace closer at home.
there are some ways to do that. In terms of seeing specialists in pregnancy, such as myself, maternal fetal medicine physicians are not very common. There are some states where there's only one hospital, one university that has
Mhm.
all of the maternal fetal medicine specialists for the entire state. There are some states where there's only one doctor, one MFM or two MFMs for an entire state. Those tend to be the bigger ones, more in the central and western part of the country. But Kentucky, for example, has one hospital location that serves almost the entire state that has maternal fetal medicine specialists. So it can be difficult to obtain the like a doctor like me to be seeing you through your entire pregnancy. That's why I did say at the beginning, sometimes I would only be a consultant. In other words, there are skilled OB doctors that can take care of these issues, but don't feel comfortable taking care of them in a vacuum. That's where I can come and work not so much as closely with the patient directly, but work very closely with the doctors who are caring for our mom with an SCI. And just to add a little bit of confidence for all of this, all OBGYN doctors are trained to be able to take care of individuals who have paralysis. Some of these more advanced spinal cord injury medical complications do require more advanced specialization, but all OBGYN doctors know how to deliver a baby, know how to do a C-section. All OBGYN doctors can definitely follow the advice and coordinate with other specialists. So in some cases, it's not necessary to have a maternal fetal medicine doctor like me on the case the whole time. And in many cases, that entire team of doctors that I mentioned earlier, that entire team isn't necessary at all. It may just be a couple of doctors along the way because a mom is very healthy and does not have very high needs. But other moms do have very high needs and need to be aware that sometimes many doctors are involved in their care.
So we've come to the top of the hour. So what would be your 3 points that you want people to remember from this session today?
Sure. So, what I think I'd like people to remember is that spinal cord injury is not a contraindication to pregnancy. The vast majority of our conversation today was how to manage with a spinal cord injury, not why you should or should not have a baby. It's just really to think that you can have a baby with a spinal cord injury that can be made safer, but there are inherent risks to pregnancy. The next thing I think I would say is that assembling a team of doctors that are comfortable with you, comfortable with your condition, and with whom you are also comfortable with is of paramount importance. And the last thing I would say is not to lose sight of your goal. If your goal is to have a child, you should be able to attain that with a spinal cord injury. Your care just may be more detailed. Your SCI may affect your pregnancy care, but you should be able to have a baby just as any other woman would. It's important to understand what those risks are, but understanding the risks and understanding how to manage them, I hope would give women confidence who wish to have a baby with a spinal cord injury.
Well, Dr. Fuller, I wish we could spend more time talking about this because you are fascinating and you certainly have laid out the risks, which are important to know, but you've also been very motivating for people who maybe were kind of on the fence, didn't know. So it's very reassuring. It's reassuring to know there are people like you out there that are willing to help. And we just wish all those women and families out there the best, because like you say, when you get that baby the first time in your arms, oh, that is what heaven is. It's just wonderful. So thank you for helping everyone with their pregnancy issues and getting those babies born. That's wonderful.
Thank you, Linda. And I would just like to say that I know sort of concurrent with this webinar, the Reeve Foundation has allowed a blog entry for one of my my contributions to the Reeve Foundation. If that's a forum where individuals who are listening to this webinar might find helpful exchange for information, I would just ask that they continue to provide feedback to you about that, and I would be more than interested and willing to support the Reeve Foundation in this type of topic moving forward. If there's an interest, I'm happy to help.
Okay, so audience, if you're a medical professional or if you're a person in the community, feel free to write in. We've got the A-OK to move ahead with this. So thank you, Dr. Fuller. It's just been wonderful to talk with you today.
Thank you too, Linda. I hope you have a wonderful day. Thank you very much.
You too.